I'm Adrienne Flanagan. I'm a pathologist based at UCL and the Royal National Orthopaedic Hospital. And Jeremy, this is what we've been asked to talk about, what clinical and basic research is happening, the challenges and gaps, which I think are clearly very important, and the direction and the opportunities, which may be open for more discussion later on. But Jeremy started his question. Where's Jeremy? Why aren't there more clinical trials? And why isn't there an improvement over the last 30 years in clinical outcome for patients with osteosarcoma? Well, the answer really is, for the vast majority of cases, patients, we don't know the cause of osteosarcoma. We have absolutely no idea. And without understanding that, it's unlikely that we're going to make a major impact. We may be fortuitous in identifying certain approaches to treatment, but I think ultimately we need to understand the pathogenesis of the disease. And we have been very lucky in the United Kingdom. About 5 years ago, the 100,000 genomes was opened. A lot of people will say it was a dreadful idea, another great idea of David Cameron, but actually, I think we've all learned a great deal from it. The idea was to see, we would be the United Kingdom, which is mainly England actually, was that we would be the first country to sequence 100,000 genomes. And the 100,000 genomes project has now completed, and they have been sequenced. But of course, this is just the beginning. Against all the odds, originally Genomics England, who run this project, did not want to involve any sarcoma. They thought it's such a rare disease, leave them alone, let's tackle breast cancer, colorectal, lung. But actually, against all the odds, the sarcomas have really done an outstanding job. A lot of this is down to the bigger units, Birmingham, Lee Jay's group, the London Sarcoma Service, Oxford, but also Newcastle, but the Marsden, many groups. But they have done a fantastic job. So samples from over 1,000 patients with sarcoma have now undergone or are currently undergoing whole genome sequencing at high depth. If we had to pay for this ourselves, it would have cost the community about £4 million. So it was done, and that doesn't take into account just the DNA extraction, the biobanking, the consenting of patients. It has been an amazing success, and the data will be a legacy for the next decade and more. Of the 1,000 patients, at least 100 of these have osteosarcoma. To put this into perspective, I started to biobank patients, the samples in the Royal National Orthopaedic Hospital in 2002, and in 2017 we published the largest sequencing data in the world. It was only 40 whole genomes and 80 exomes. In 2 years, we've managed to sequence by partnership, by a consortium, by coming together. We have sequenced over 100 patients with osteosarcoma. That's to demonstrate the power of working together collaboratively. And we will be able to bring in existing data into the Genomics England research environment to add benefit to the cases we've already that have recruited to this study. There are 2 streams of output from this from the 100,000 genomes. The first is the genomic tumor boards, which are being set up around the country. And I am just going to talk about the London one because these are very in the early stages, but they are proving enormously beneficial. Sandra and Vasilius, the oncologists, play a major part, as well as the pathologists. What we found is we're not always getting our diagnosis right. At the moment, however, it probably doesn't matter because the treatments are the same, but the subclassification, we're changing them in a percentage of cases. We're identifying germline mutations. We're also identifying potential therapeutic targets. But it's probably, we need to distill all of that data really and crystallize it to learn from it. And one of the extremely interesting things, at the RNOH, we recruited 1,000 patients. We consented 1,000 patients in 2 years to this study. However, only 550 patient samples went for whole genome. The rest of the samples were not suitable. Why? We actually now are drilling down through that data to see why. Some of them will have had preoperative radiotherapy, preoperative chemotherapy, a whole variety of reasons. But we need to know those reasons if we're going to be able to actually, if we're going to use data, genetic data and human data, we need to make sure that we can get the samples. We don't know at the moment. We're only getting 50% of the samples to use. We must be able to do better than that. And so from the sarcoma genomes, we actually have about 2,500 genomes to analyze. Why? Because, of course, for every patient, you have to do 2 genomes, their germline and the tumor. But on top of that, due mainly to the Tom Prince Trust, who we went to speak to Genomics England, and they allowed us to collect multiple samples, particularly from osteosarcoma, for the purpose of the 100,000 genome study. And the RNOH put in an extra 500 samples, many of these from the osteosarcoma patients. And so the study of heterogeneity and tumor evolution, we can now exploit this. So the other stream of information that's coming out of that 100,000 genomes, the tumor bores is a very minor component of the data. But to do the research, it's coming out through the Genomics England Clinical Interpretation Partnership, the GSIPs. And there is a sarcoma GSIP. And that has brought us together. 40 of people, presumably around, most people around this room, but also around the country, joined in this partnership, this consortium, to tackle sarcoma, all sarcomas. And we put in a grant to the Sarcoma UK, and we were awarded it £250,000 for a bioinformatician for 3 years and a technician to start the analysis. So you can say, well, we've got all these genomes, why don't we just get the data? Because cancer is a genetic disease. Deep in that DNA that we have now from these patients, the cause of the disease is hidden. We need to analyze it. But actually, analyzing this amount of data is phenomenally difficult. The largest publication and the largest study done on whole genomes ever on a pan-cancer study has only been 2,568 cancers. From sarcoma alone, we're going to have 2,500. So we are exceptionally lucky. The person who led this study, the pan-cancer genome, the largest study of this type in the world, is Peter van Loo. Peter van Loo is going to lead the sarcoma genomics GSIP for us in terms of the genomic analysis. I mean, that is fantastic, and he has a great track record to be able to do this. So with the GSIP, this is bringing the whole sarcoma community together. Peter van Loo is the genomics lead, and we are also extremely lucky to have a germline genomics expert who is Garrett Bond, who is sitting very humbly at the back of the room. Actually, he's standing so we can see him. Hello, Gareth. And we're also working collaboratively with David Thomas in the Kindred study. The reason that these 2 people are kind of the prominent people at the moment in this research is because Genomics England has produced the data from the sequencing. But if we want to do any further research, the genomic data, the transcriptomic data, the methylomes, all of this we need to fund. We need to go back to collect the material, analyze it, and then integrate it. So as I said, cancer is a genetic disease. The cause, the drivers is in the DNA. So why bother looking at the epigenomics, the transcriptomics? Well, we know that the methylation changes, which are probably driven by the genetic changes, although some people will argue about that, and the transcriptomic changes, they can be targeted. So you don't only target the DNA at the genomic level, you can target it at the epigenomic level and potentially at the transcriptomic level. So that's why we need to follow on from the genomic level and follow on with these 1,000 samples to do the transcriptomics and the epigenomics. And we're extremely lucky, as the epigenomic lead is Stefan Beck. He was involved in the sequencing of the human cancer genome and has a tremendous expertise. And we have transcriptomic Sam Bajati and Paul Huang. But this is really the beginning, right, of this GSIP. And just, so you might say, well, we should be just studying osteosarcoma. Well, I'll just give you one example as to why I think it is beneficial to study all of the sarcomas together and then actually downstream look at it disease specific. We know that the cause of osteosarcoma, in many cases, we don't know what the cause is. But in a percentage of patients, it's driven by germline alterations. And these germline alterations are probably most common in sarcomas than in any other disease. So we can learn a great deal from studying the germline alterations, and Gareth, of course, will lead this. We also know that a percentage of patients with osteosarcoma, but also other carcinomas, is driven by ionizing radiation. And from the work that we, the samples that we had biobanked over the years, we have identified a signature, an ionization radiation signature. And actually that same signature is in all of the different sarcomas and also in prostate carcinomas and in breast cancers, if there are other different types of cancers due to the radiation. So there are benefits about doing large-scale analysis and not just working on osteosarcoma purely in isolation. So this is just the Jiseop meeting. The first of its kind is going to happen on the 14th of March. I got a very good deal with the Royal College of Pathologists, not just because I'm a pathologist. And there we will have a meeting which we really want to make this inclusive, multidisciplinary, and collaborative. So we know we've got the data from the 100,000 genomes, from the genomes, to study the genomic data and the germline data, the somatic and the germline, but there's many, many other things to do. The biomarkers, the imaging, the pharmacokinetics, deep learning, and particularly the developments of models of disease. So actually, this is an opportunity. The nidus is the GSIP in terms of that is the data. The cause of cancer is in the genomes. This is the nidus, but it will bring us together in terms of a multidisciplinary approach to study sarcoma and, of course, osteosarcoma. So where do we go from now? The 100,000 Genomes project is completed. Well, we are very lucky that all patients with sarcoma potentially can have their genome sequenced prospectively now. Okay, there is a break, but we think as of the 1st of April, patients with sarcomas, their genomes can be sequenced. That, of course, must be managed properly, but actually, if patients, it will build what we have from the 100,000 genomes and give us a really larger resource. On top of that, of course, we have the BRC-funded project with Sandra's leading and funded generously by the Bone Cancer Research Trust, which will be collecting the data from all of these patients with osteosarcoma, for which we hopefully will have whole genomes. However, the funding will only now sequence one sample, so maybe we need to be looking for funding for multiple samples to look for the heterogeneity and understand tumor evolution. Bone Cancer Research Trust has also funding the 5 different bone tumor units to collect samples. Thank you, Zoe. And of course, the Tom Prince Trust Tom Prince is a young man who died at the age of 17 with osteosarcoma, and his family has also contributed and continues to contribute substantial amounts of money. And some of this money will go along in parallel with the Bone Cancer Research Trust to do the more analysis and the basic research. Some of you may not know that there is a huge shortage of pathologists in the United Kingdom, and that has been a challenge. It's a challenge not just in the UK. And all of the bone tumor pathologists came together about 2 months ago. The Scottish pathologists joined us. They're a separate network, but they're very keen to form a network. And we have agreed that what we want to do is establish a seamless research and clinical service so that patients can really benefit from this. So we are going to have a network across the country. So if one unit is short of a pathologist, hopefully we can share standard operating procedures and we can support each other. Secondly, we will also have a network manager to align all the trusts in terms of the management of this. And this high-level manager will also link into the Jiseop to make sure that the NHS and the research component actually work together. This post has been advertised as of today, and it's quite a high-level senior manager to bring us all together and administer this. You also asked me to talk about some of the challenges and gaps. I think a huge challenge is managing everybody's expectations. As Stefan said, and Sandra, of course, we haven't really made any major advances in the treatment of osteosarcoma in 40 years. The 100,000 genome has been done, but this is not an overnight solution. So we need to manage everybody's expectations, and today in this world of hype and social media, actually it can be very negative and be very frustrating for many people involved. I was in China last week, where we saw this patient with a uterine sarcoma. She clearly was going to die and had very advanced disease. And we talked to her, and then out of her pocket she pulls this envelope with a whole genome sequence having been done. Nobody knew how to read it. There was clearly no treatment for it. In isolation, one whole genome, I don't know who paid for this. I mean, it was hopeless. However, so I don't think whole genomes is the answer for tomorrow, but compiling all of that data in a research profile, in a research consortium, and actually building on it, then it becomes very valuable. But we can't tell patients that the whole genome is going to solve their problems tomorrow. Healthcare workers, I think it's a very fast changing world. We need more education. So healthcare workers can speak to patients about their expectations, and also healthcare workers need to understand what a whole genome is. They need to be able to interpret it, but they need to have a basic understanding if they're talking to patients, because patients will be asking the questions. Research scientists, we have a huge skill shortage. Trying to find bioinformaticians, computational biologists with the skills to study these 2,500 genomes is almost impossible. If you can't do that really at a high level, that data is going to lie there unexploited. And because of the 100,000 genomes, there are so many jobs, it is becoming quite clear there is not the expertise. And of course, with Brexit, it's not doing us any favors. I mean, it's really hopeless. And I think also managing the expectations of the funders and the patients who generously give to us. There will be minor advantages and benefits all the time, but we do need to manage everybody's expectations in a very positive way. So I think my message is that The research will be very multidisciplinary. As Craig has talked about the surgery, the clinical trials, the radiotherapy, but ultimately it comes back to what causes the cancer. It's damage to the DNA. We don't really know how radiation causes cancer. We don't know why some children get osteosarcoma. That is hidden in the DNA, and here is a huge advantage for us all to work together to make advances. So thank you.